Hello, everyone. Thanks for coming back. We're really excited to kick off this fourth session on health policy in the healthcare system, and we're looking forward to the talks that our MD PhD student and the faculty speaker will be giving tonight. And so I'm very happy to hand things off to our session boss, Chelsea Lee, who coordinated this event.
Hi, my name is Chelsea. I have the honor of introducing our guest speakers today, and I'll go ahead and start by introducing our student speaker, Dr. Jeremy Fine. He is currently a PhD graduate, and he focuses on improving mental health outcomes. And a little bit of his background: he graduated from Washington University in St. Louis in 2019 with a degree in philosophy, neuroscience, and psychology. And so today he'll be talking a little bit about insurance terms and introducing the topic for our faculty speaker. So I will let him take it away.
That was the first time I was ever introduced as Dr. Jeremy Fine, so that's kind of wild. Don't know how I feel about that yet, but okay. So I'm Jeremy. I'm a health policy PhD, and I thought a good topic to talk about today would just be how insurance works, because it's really confusing and there's a lot of really confusing terms. You've probably come across a lot of these, and you might know all of them already, in which case, awesome. But especially as we utilize more and more healthcare, just kind of knowing how these things work in daily life is beneficial. So feel free to interrupt me if you have questions. What I'm going to do is I'm going to run us through just this one case, and we're going to learn just how much things cost, why things cost the way they do, even though you have insurance. So here's our hypothetical scenario. Jane Doe is a RA, or a research assistant at UNC, and she has the research assistant insurance, which is the one that all of us students have during grad school. And she goes to the ER because her knee hurts. So in this scenario, we're saying a doctor first provides an exam, and they do an x-ray, okay? Something typical that could happen. The x-ray didn't show anything, so the doctor recommended an MRI. She said you could go home and you could do an MRI here, or you could do it later on, but there was no reason to keep someone in the ER for what they were dealing with, okay? The wait at UNC Hospital was 3 weeks, but there was no wait at the imaging center down the road, at this private imaging center, okay? And she gets an MRI there the very next day. So very realistic, typical situation that could happen. Everyone following along with that? Making sense? Great. Okay, so this is what my insurance card looks like, and what most people's insurance cards looks like. So we are going to go through what each of the things mean on the insurance card, and what they mean for you while you are paying. So the first thing we see up there is the DED. It says in-deductible and out-deductible. We'll talk about the difference there in a second. But deductible is the amount you pay before the insurance pays anything. So if you buy insurance, you pay a certain fee every month. We'll talk about that in a sec. But then if you go get some healthcare service, you have to pay a certain amount before the insurance will pay anything back to you. That's called the deductible. There's also often something called an out-of-pocket maximum. That's the amount you pay before the insurance pays for everything. So you can see here, there's two numbers for out-of-pocket maximum. There's this in-network and this out-of-network out-of-pocket maximum. So the difference between in-network and out-of-network is the insurance company makes a deal with a certain set of doctors, and they agree on what rates to charge. So those are all considered in-network, but all the doctors out of network, they don't have agreed upon rates, so they might charge a little more. Your insurance will still cover you usually, but sometimes it might be a bit less. They might pay you a little bit less. So that's why in network, your insurance says the max you can spend is $2,000, whereas out of network, you have to spend $4,000 before they pay for everything. Make sense? Like I said, a premium is the amount you pay in monthly fee. This large bucket here is the revenue for the insurance company, and that just goes into that bucket. And we're going to talk about what goes into these other 4 buckets in a sec. So back to our scenario. Jane Doe has the UNC RATA plan and goes to the emergency room for a painful knee. Okay? So that first step is she goes to the ER. That costs money. So the amount that it costs, you can see on the insurance card here, says ER, and that dash is in network. So for her to walk into the ER costs $100. So that goes into this bucket here, which is the total amount spent in network. That flat fee amount is called a copay. If you've ever heard the word copay, it's basically a toll. It's a toll you have to pay for walking into the emergency room. Okay? Something else you'll notice about the copay is that it usually does not go into that bottom bucket where the deductible is. So even though you've paid $100, it doesn't usually go into the bucket you have to fill before the insurance pays. So you've paid $100 and your in-network deductible is $400, but that $100 does not count towards that $400. So the prefix co, by the way, usually indicates that you're going to be paying something, and the insurance company is going to be paying something as well. In this case, the copay, you're the only one paying something. So I guess the rule doesn't fully work there, but it does for the rest of the time. And like I said, co-payments do not work towards deductibles. It's just money that goes directly to the insurance company and eventually back to the healthcare facilities. Okay, so let's say this exam is $400. Okay, she went to the ER, she got an exam, the exam is $400, and the x-ray is $100. When I made this, that was a little bit high, but by now that might be realistic. Prices continuously go up. So she went there and she got this exam. Where does the $400 go? Well, $400 is equal to Jane Doe's in-network deductible. So she pays $400 for the exam, and after that, her insurance will start to kick in because the $100 that she had to pay as a copay did not work towards her deductible. Okay? Great. So now the deductible is met. The total amount she has spent in network goes from $100 to $500. Okay? And now she gets this x-ray. Well, her in-network deductible is met. So how much is the insurance going to pay now? Well, if you look up here, it says co-insurance in network. So co-insurance is a split. You split the cost with the insurance company. And it says here that 20% is on you after you meet the deductible. Okay? So 20% of $100 is going to be on Jane Doe to pay, and the insurance company will pay for the other 80%. So Jane Doe pays $20, 20% of 100, and the insurance company pays $80. That $20 goes into the total amount she spent in network, and the insurance company paid the rest of the bill for $80. Okay? Y'all following along here so far? Excellent. Like I said, feel free to interrupt me because these things are confusing. So, back to our story. We said the x-ray showed nothing on it, and the doctor recommended an MRI. The wait at UNC Hospital was 3 weeks, and Jane Doe's knee was killing her, so she didn't want to wait that long. Very understandable. So she went to the out-of-network private imaging center down the road from her house, okay? and she got an MRI there the very next day instead of waiting for 3 weeks. So her insurance company says that an MRI should cost $1,000. MRIs aren't cheap. Now, this is out of network, right? So all the money that Jane Doe pays has to go to this out of network deductible. This out of network deductible is $800, and the MRI costs $1,000. So the first $800 of that $1,000 goes to the out of network deductible. And now that also works towards the total amount she has spent out of network. Okay, so $800 has been met of the $1,000. How much is left? $200. And if you look at this insurance card, of that $200, the insurance company is going to pay 40% after the deductible. Sorry, excuse me. You are going to pay 40% after the deductible. The insurance company is going to pay 60%. Okay, so 40% of 200 is $80. That's what Jane Doe paid, and the insurance company paid $120. So that's it, right? Capitalism. So the imaging center actually says that the MRI should cost $2,000, even though Jane Doe's insurance company says it should cost $1,000. Well, the insurance company hasn't negotiated prices with this out-of-network imaging center, and because of that, there's a $1,000 difference between what the insurance company says this should cost and what you are actually charged when you go to the imaging center. And this is called balance billing, and you are on the hook for that $1,000. And it doesn't work towards any of this. It's just the difference between what the insurance company is willing to pay as a service for an out-of-network provider and what the actual cost is. So you spent $520. Sorry, not you, Jane Doe. I wouldn't wish this on you. Jane Doe spent $520 towards her out-of-network, out-of-pocket maximum, in-network, out-of-pocket, $880 towards the out-of-network, out-of-pocket, with an additional $1,000 because this imaging center says they have very fancy MRIs. In total, you spend $2,400. The insurance company paid for $80 of the in-network ER visits and $120 for the MRI scan to total $200. So even though Jane Doe has insurance, she paid for 92% of the cost of this visit. And that's a very depressing end to the slides. But we can briefly talk about, so when would insurance be more valuable? If you have really high expenditures, if you expect or live with a condition where you expect to have to use care frequently, especially for young people, insurance is worth having because something awful could happen, and it is not always as cost effective as it is for older adults who might use healthcare more, or individuals who live with certain chronic conditions who might already know they're going to the doctor more often. So happy to answer any questions. I hope that helped. I hope you don't have a balance bill because that's not fun. And thank you for listening. Amber.
Thanks. Does that have a major?
Oof. Yep. Goes to the imaging center. Yep. Yeah. That's a great question. It restarts every time your insurance renews. So usually on your insurance, let me see if it was on, I cut it out of this one, but usually there's an effective date on your insurance card. And every time there's a new cycle, those buckets empty out, which is why there's oftentimes weird enrollment periods for insurance companies, because they want to make sure that you are not enrolling right after you got sick or something like that. And it's also why sometimes people might put off going to the doctor for a longer period of time to wait until some deadline has passed. Or they might see multiple doctors in quick succession because they know their plan's going to renew. So knowing those dates can actually be pretty helpful. One random important tidbit I'll add: if you or anyone you know is about to turn 65, it is really, really important that you enroll in Medicare Part B within, I think, 36 months. Thank you. Within the first 6 months of turning 65, because if you don't and choose to enroll later, it could cost you more for the rest of your life. So doing that as soon as you turn 65 is really important. So tell your friends, tell your loved ones, write it down, whatever you need. Oh, yeah. You're good. A referral? Yeah, the question was, is there a benefit to getting a referral? Um, so I guess it depends how you define benefit. Because maybe you'll get a referral to a really qualified doctor, but if that doctor's not in your network, then you're going to have to pay more. So you don't get any discount or anything like that for having an in-network doctor refer you to somebody else. You can go on the insurance company's website to see which doctors are considered in-network. Even more than that, something I learned recently: different pharmacies are in-network versus out-of-network. So you could get your I pick up my medicine at the CVS on Franklin Street and found it was cheaper at the Harris Teeter on Estes, just because my insurance company has some deal with Harris Teeter. So, yeah. Yeah. Yeah, that's a great point. Yeah, there's some doctors you can't access without having a referral. So if you want to see a specialist, you might need to see either a primary care doctor first or an ER doctor first, or have somebody kind of route you to them. So that's a great point. You can't walk in the door everywhere. Yeah. That's a great question. And I know what you're referring to too. Yeah, I want to make sure I say this right, so tell me if I say it wrong. Sometimes if you go to CVS to get a vaccine, it can be affordable, whereas if you go to like a hospital like UNC or a different provider, it could end up costing a lot. Um, my intuition, and you can please, Dr. Zachary, tell me if I'm wrong, is that sometimes, like during the COVID pandemic, the government like worked and maybe cut a deal with some pharmacies to offer things at a lower rate compared to other places. Honestly, that's all I got. That's a really good question. Yeah.
Thank you, Jeremy, for that great talk. Is the PowerPoint up on Zoom? Great. So now I'd like to welcome our faculty speaker, Dr. Ciara Zachary, and I will welcome Chelsea Lee, our session boss, to come back and give a formal introduction.
I have the honor of introducing Dr. Zachary. And so Dr. Zachary is an assistant professor in the Department of Health Policy and Management at UNC's Gillings School of Global Public Health. She serves as the Assistant Dean of Master's Programs, and her work focuses on health policy research and advocacy aimed at improving access to affordable, high-quality health coverage, particularly for the underserved communities. Um, Prior to joining UNC, Dr. Zachary led many policy initiatives and collaborated with legislators on issues including Medicaid expansion and the Affordable Care Act. She also has extensive experience in program evaluation for projects on reducing non-completion of high school, especially for students in low income or low resource communities. And she's also, as well as like health policy analysis, both at like the federal level and the local level. Dr. Zachary's work is driven by a commitment to advancing health equity and addressing health disparities through evidence-based policy. And so today she'll share a little bit about health policy, practice, and advocacy. Thank you so much for speaking to us today.
Thank you, everyone. And I just want to also, I know that Dr. Fine isn't here anymore, but great job. I might want to steal those slides to help explain all those really complicated terms. So like Chelsea said, we're going to talk a bit about some of our higher like federal level policies, then talk about practice in the workforce, and then something that I'm really passionate about is advocacy. Probably also going to move over here so I can walk a little bit more. I invite all of you to ask questions if you have them, just because it's complicated. Sometimes looking at your explanation of benefits is like looking at a menu at the Cheesecake Factory. You're just looking through pages and pages and you don't understand. So I thought that was really helpful exercise to like walk through the terms that are on your insurance bill. So let's get started. All right, so this is our agenda for today. We're just going to talk a bit about what is the U.S. healthcare system. Like, I would invite you all to share, like, what do you think about when you think about the U.S. healthcare system? Then we're going to go over some major U.S. health policies. So let's talk about Medicare, Medicaid, the Affordable Care Act, Medicaid expansion, and then we will talk a bit about the One Beautiful Bill Act, or H.R. 1. And then, you know, I think everything is so connected. So some of you are med students or other types of practitioners. So how are these policies going to impact the work that you do? And then finally, we'll try to give some tips on like all of us can be advocates. If you want to be, there is an entry point for all of us. And so again, definitely welcome any kind of feedback and questions you might have. All right, so let's kick it off. When you think of the US healthcare system, I think Dr. Fine really set me up well with such a depressing result of just needing an MRI at the nice fast clinic down the street. But what do you think about when you think of the US healthcare system or the structure? I see just like a mug. No, there isn't one. Is okay. Anyone else? Good experiences, bad experiences, bleh. We could improve. Yeah. So I think those are natural thoughts. I think, unfortunately, too many of us have probably seen on social media people using GoFundMe as a way to be able to pay for healthcare that they need. And so we'll just move on. So I would kind of say in some of the classes that I've taught is that it doesn't seem like a unified healthcare system. It's like this patchwork, and it really kind of depends on what type of person you are. So are you a baby? Are you an older adult? Are you working? Are you unemployed? Do you have a disability? So all these different things can shape the way you navigate our US healthcare system. So overall, I kind of say there are multiple systems that interact to greater or lesser degrees. So you might be a person where you've been on your parents' health insurance plan your entire life. And then unfortunately, you might turn 26 and you're like, what do I do? I'm still in school. I don't have a job. Maybe you're able to get the UNC student health plan. Maybe you're like, hey, I live in North Carolina and we expanded Medicaid. I'm going to get on Medicaid. Or maybe you have a different story. Maybe you're one of the 50% of children that is born with Medicaid coverage and you stick on Medicaid throughout your young adulthood growing up, and then you get a job, and then you have employer sponsored insurance. And then you're like, I'm just going to wait till I'm 65 and finally get that Medicare. So there's a whole lot. We also have for-profit and non-for-profits. We have our teaching universities. We have urgent care places that we can go to. And then it's also really complicated because our healthcare system is financed by both, governmental and non-governmental entities. So when we think about Medicare, we may think of the federal government, and then we might think of our employer-sponsored insurance, where we are working with the Aetnas and the Humanas and the Blue Crosses of the world. And then we don't have universal coverage. So this is midterms. We'll have another election cycle. We might start hearing that Medicare for all slogan. So kind of thinking, can we get rid of this patchwork in the US? And then despite the Affordable Care Act and having Medicaid, I would say we have still far too many people who are underinsured, which means, it's still hard to make ends meet, to pay for their health care. And we have way too many people who remain uninsured, whether that's because of their documentation status or because of changes in policy that makes it harder for you to afford health care. Here's just a little bit more. Sometimes we use a lot of jargon. We might say health coverage, which might not necessarily mean insurance. And we'll get a little bit into that. In other countries, they may have, insurance or different types of coverage. A lot of times it is public. And then, there may be more than one way for people to get covered. Or if there is like a universal coverage, people can opt to buy additional coverage. So here we go. This is an old image. But we have our U.S. veterans and we have Indian Health Service, so our indigenous populations. That looked more like the British National Health Plan. But then we have our employer-sponsored health insurance that might look more like going to Germany. And then we have our Medicare, which is like mostly our socialized healthcare that may look like Canada with a single payer. And then, we don't have this many uninsured folks, but this may look like some of our lower income or less developed or industrialized countries. How are we feeling? Now we're going to move into big P policy. And a lot of times I say the P is for like the federal level. So we have a lot of policy or, guidance from the federal government. But then our states can sometimes interpret things, or your states can make extra efforts to offer affordable health care. And then maybe you live in a county or municipality that is taking initiatives. How many of us have heard of the word like social determinants of health? Social determinants of health. So this is like basically saying where you live, where you work, where you go to school, all impacts our healthcare. Maybe you live in a county that's doing extra things that makes it easier or more, helps you get food that you need to eat, or has, maybe housing things. So these are ways that you are improving your health that might not be a federal policy. All right, let's start with Medicare. So the reason why I think Medicare for all is a slogan that we might hear during election season is because it is our only version of single payer universal coverage. So yes, before you turn 65, maybe a few months or a year, you might start getting those mailers from AARP saying like, let's get ready, sign up, educating you about how the sign up process is. But I would say it's not just folks 65 and up who have Medicare. Some folks with disabilities, if they have Social Security disability insurance, they may qualify. There are also other folks with complex health conditions that may also have Medicare. One thing is Medicare is administered solely by the federal government. I know that there are more Medicare Advantage plans, which gives you like maybe that private insurance card like Blue Cross. but they still have guidance from the federal government. And then also, again, it's a social insurance program. So it is paid a lot of times through our payroll taxes. So when you get your paycheck, you might see that little bit of amount that goes back into Medicare. But Medicare itself is really complex. You have Part A, you have Part B, you maybe have Part C, Part D. And then we also just think about, with the aging of our population, what is Medicare going to look like? I know that there are talks about, should we up the age to 67 so that we can control costs, or how many people have Medicare coverage? Or some people even say, let's lower the age to 64, 63 and let people opt in and buy Medicare coverage to kind of balance out the risk pool. That's another term that maybe Dr. Fine can come back and teach you about. But, and then how many of you have heard about, like, is Medicare going to become insolvent? Yeah, this comes up every now and again, saying like, oh, in 2031, Medicare is going to run out of money. I'm just going to say that's just one part of Medicare and how it's financed through those payroll taxes. So these are definitely discussions. So while Medicare sometimes feels like a sure thing, I don't know, things could change in how we finance the program and who becomes eligible. I am not going to hide my bias. I love Medicaid. I feel that it should be Medicaid for all. And the reason why I love Medicaid is that it is an entitlement program. So if you are eligible for Medicaid the way it is today, before the One Beautiful Bill Act kind of gets into effect, you are going to get coverage. So it became law in 1965. And it really only covered the deserving poor. So we thought about pregnant women, children, people with disabilities, and some older adults. With the ACA, we have expanded who can qualify for Medicaid. The difference between Medicaid and Medicare, besides who has it, is also that it is jointly administered with the state and the federal government. So I like to say, if you understand North Carolina's Medicaid program, you only understand North Carolina's Medicaid program. You move to another state, maybe there's different benefits or services that are offered in the Medicaid program. Maybe how it's run is a little bit different. I do think there are sweeping changes because of the One Big Beautiful Bill Act. But overall, this gives states the ability to be flexible and design Medicaid in a way that they think meets their population's needs. So I would say North Carolina, folks are really lucky in that North Carolina's Medicaid offers adult dental services. Medicare doesn't offer dental services, just wanted to tell you. Another Medicaid is also really important for our older adults with low incomes. Medicare doesn't cover long-term, care. It's actually for some of our older adults who need to live in, facilities. It's Medicaid that usually chips in for that. Medicaid is also really important for children. There's this benefit for kids called EPSDT. It stands for Early Periodic Screening, Diagnosis, and Treatment. So it's saying even if it's not a covered benefit, children should be able to get services so that they can grow up into healthy adults. So that's Medicaid. Any questions? All right. So now we're going to move to the Affordable Care Act. I think there are some of us in the room that remembers the health insurance world before 2010, which was when the ACA was passed into law. And so there were lots of gaps in coverage. And that is why the ACA, I think, despite maybe some of the bumps along the way, is in such an important piece of legislation, is that before the ACA, you could be discriminated against based on pre-existing conditions. So a pre-existing condition could be many things. It could be, I had knee surgery and now the insurance company doesn't want to cover you. There wasn't a lot of parity between mental health care and physical health care. So now with the ACA, that has been an initiative to say that there really shouldn't be limits on how often you can see a mental health care provider compared to if you wanted to see your primary care provider. Also, just how much, gender differences, people who identify as women should not have to pay more for health insurance than men. And so really trying to balance some of those things out. more gaps in our healthcare. So one of the biggest provisions in the Affordable Care Act was Medicaid expansion. We talked a little bit about Medicaid and that there were really more strict eligibility criteria to be eligible for Medicaid. With expansion, it said, let's get rid of you having to fit into a certain type of person or be able to check a box. As long as you make under 138% of the federal poverty level, which I believe is about, I think for like a family of 4, that's about like $40,000 these days, you should be able to get on Medicaid. As we know, we still have about 10 states that haven't expanded Medicaid, and I think we'll be at a stalemate, moving forward. But I think that this is one of the, biggest provisions in the Affordable Care Act. So Obamacare, the ACA, whatever you want to call it, it really built on, I would say, like the 3 legs of our healthcare stool. It went for public coverage. So thinking about Medicaid, expanding that coverage. It also had some provisions that impact, those of us that are fortunate enough to have employer-sponsored insurance, kind of thinking about what are some of the, benefits that need to be offered, how can we control for exorbitant costs. And then it went to individual non-group coverage. So that might be what you're familiar with hearing, is like the marketplace. We heard a lot about that last year because there was a whole government shutdown because these extra financial help is going away for folks. So anyway, instead of people being uninsured or having to go to a health insurance agent or broker and spend a lot of money for folks who have different kind of working situations, it created the marketplace, which is a place where folks who have certain incomes can get financial help. And if you don't have fall within a certain range, you can still go to the marketplace and find a plan. Let's say if you're a contract worker or you're a part-time employee or you're in between jobs and you're waiting for your insurance to kick in. This didn't cross over as clearly as I wanted to show, but this is just to show that the ACA made a difference. It was passed in 2010. And so look at how many folks were uninsured. We had 46.5 million. And now it actually ticked a little bit up recently. But at least from these data from 2024, we were down to about 27 million folks who were uninsured. 2020, I think we might still be trying to block the memories of COVID out of our brains, but data were definitely a little bit sketchy in those years. So I think, overall, the Affordable Care Act has been, really beneficial in expanding coverage for folks so that we don't have as many uninsured people. There have been some changes to how many folks are uninsured, but I think we've made significant progress. And there are so many more policies in between that I'm not going to get a chance to go through. But I do want to talk about Medicaid expansion because when I did lobby and I worked for the North Carolina Justice Center, this was like my pet project, my baby. So many meetings with legislators, doctors, nurses, all types of people to say North Carolina needs to expand Medicaid. So we are now amongst the blue. We expanded Medicaid in December of 2023. We have over 700,000 North Carolinians who have health insurance now, who before didn't know where they were going to go, or they had to pay so much out of pocket to maybe get marketplace coverage. Something else that North Carolina that I think links to Dr. Fine's talk about surprise billing and how much people might end up. And unfortunately, we hear these stories about folks, basically going into significant debt because of healthcare. Under Governor Cooper and when it was Secretary Cody Kinsley, they passed some legislation about medical debt. And I think a few months ago, they released the numbers. $6.5 billion of medical debt has been erased for people in North Carolina. So just think of that's just for North Carolina, one state. So we are making progress, and that's an example of a state policy that can help people be able to afford healthcare. So in the early days of COVID, I just wanted to bring up, it doesn't all have to be the Medicares and the Medicaids and the Affordable Care Acts that are significant health policies that shape how we access healthcare. So in the early, moments of the pandemic, I think Congress realized like this is a big deal. It's a public health emergency. People are not going to work or losing their jobs because we were all in like a shutdown. What can we do? A lot of times Congress can step up. So there was the Families First Coronavirus Response Act. And so what that did was actually give states more money to take care of folks with Medicaid. Medicaid is counter-cyclical. So when the economy is bad, actually more people probably need Medicaid because they're losing their jobs or don't have as much. And that puts a strain on the budget for the states. And historically, when there has been economic downturn or a great need, Congress actually gives states more money to implement their Medicaid program. So it actually gave more money to states, and it also told states, you cannot disenroll people. That was that continuous enrollment. So we recognize that this is a public health emergency. It's a pandemic, unprecedented times. How many times did you say that phrase over those years? So that was something that was like a really important policy at the time that I think helped us get through the pandemic. Our most recent big healthcare policy, oops, I'm just realizing the sponge of the mic fell off. Another big bill that passed last year is the One Big Beautiful Bill Act, or HR 1, or you could say Public Law 119-21. And so a lot of folks recognized during the first Trump administration, there were endless efforts to repeal and replace the ACA. What was different this time? This time they used a reconciliation, so you don't need as many votes in the Senate. So that's why it moved so quickly. And there are a ton of provisions. I could probably speak this entire time just about what's to come. But it was signed into law. And then finally, the Congressional Budget Office released the finances. And so we are expecting millions of folks to lose health insurance as these provisions in this act are passed. All right, so just predictions about the ACA marketplace. Typically, open enrollment period, you have open enrollment even for your employer-sponsored insurance. For the Affordable Care Act, usually open enrollment starts in like November, December, and it goes all the way to mid-January. One first thing is that they cut it to go until just middle of December. So kind of shortened open enrollment for a month. So right there, you're giving people a smaller window for folks to just get insurance there. It also ended the special enrollment period. That's what SEP stands for. So during the COVID times and under the Biden administration, it was saying, if you make a certain amount of money, you can, declare that you need to get marketplace insurance. Now people have to wait. And then they're also saying that they want eligibility verification, or you have to pay $5 monthly until you prove that you are in fact eligible for marketplace coverage. This chart here is just showing how maybe this was an earlier chart before the bill was enacted, but just showing how many people will probably lose coverage. This was the big thing that happened in the news with the shutdown, the enhanced premium credits. So under the Biden administration, through the Inflation Reduction Act, even more money, financial help was given to people to get health insurance. And I think we have seen about 4 million fewer people enroll in the marketplace coverage as a result of the expiration of these tax credits. Here are some more provisions. So DACA recipients are no longer considered lawfully present, so they are now ineligible for marketplace coverage. You have to put more evidence of your income. And then once work requirements take place for Medicaid, you can't lose your Medicaid requirements because you're not working enough and then go to the marketplace. It's going to lock you out of even marketplace coverage. So we can see a trend here. this act is going to reduce the number of people who are going to be able to access healthcare or have health insurance. All right, that was a lot. Any questions? All right, breathe deep. So policy does impact practice and our workforce. And I'm mostly going to focus on the HR1 or Big Beautiful Bill Act. One of the main things is that it is going to put some caps on how much students can borrow. So if you are not from a wealthy family or you don't want to have a ton of student loan debt, this bill might deter you from going to graduate school or dual degree programs because there is going to be a cap on how much you can take out. There are also some changes in some income-driven repayment plans. So that might skew the pipeline, and that maybe folks are like, you know what, I don't want to be a primary care physician. What is it, the road to wealth? I'm going to be a radiologist. What is it, oncologist, or I forget what that acronym stands for. But I think if folks can't afford to go to school and get these credentials and become providers, because they can't afford it, it is going to impact our pipeline. And so, it also has a lot of provisions about immigration, which may not seem linked to our healthcare workforce or how we practice. But the United States, whether it is for a medical provider or a nurse in a nursing home or a home health aide, we have a lot of immigrant workers in our healthcare workforce. And before this bill, there was recognition that for some of the workforce shortages that we might expect in the future, given demographic shifts in the United States, relying on immigrants immigrant workers is going to be one way that we can address workforce. And this image here is just showing how many immigrant workers, or physicians with H-1B visas as our workforce. So it is significant in certain areas of our country. And so if we limit who can come to this country and practice medicine or become a health care provider in another way, we may feel those effects as well. It might also, impact where you practice. So with Medicaid work requirements and the reduction of money that, if people lose insurance and they no longer can pay, some of our fragile hospitals and healthcare systems might risk closing. So where do people go to get their care? And then it's also going to restrict Medicaid financing. So for many states that expanded Medicaid, there's like a tax on hospitals, and it's limiting how much we can maybe tax some of our providers or hospitals to help pay for Medicaid expansion. So that might put the squeeze on state budgets, which may trigger some states to say we can no longer afford to have Medicaid expanded. All right, and then there is this Rural Health Transformation Plan. North Carolina did get $213 million. Sorry, there should be an M. And so North Carolina does have with some of that funding. They do want to focus on rural workforce development, thinking about training and pipelines. So that might be a little bit of a silver lining. But then when we think about the reduction in Medicaid reimbursements of 21%, not sure if $213 million is totally going to balance things out. Well, that was depressing, maybe. But I always get excited when I think about policy advocacy because I do think our voices are important and our experiences, and hopefully we can see some change in the future. So when you think of policy making, this is what the CDC kind of says, is that, whether you're a researcher or if you're just a person living in your community, you might identify a problem. And then we need the researchers and the folks who want to crunch data and look at all the numbers to do the analysis. So really thinking about how is this problem significant? What is the evidence of other policy options that might be able to address this? And then we might think of our strategy of policy development. I wish it were as easy for us to just call our state legislators or write a letter and say, I think we need this policy, and then, we have magic fingers and it just happens. But there needs to be, intentionality and strategy. And then we need to, if we're successful, the policy is enacted, it is implemented, and we have to think about all of that. Speaking of the ACA, the first open enrollment, there were so many glitches and people were complaining and saying the ACA is horrible, we should have never done it. And a lot of times implementing policy is iterative, it takes time. And then we have to think about, does this policy look the same way everywhere? Certain areas might need different resources, or if you live in an area where there are a lot of folks who speak a different language, maybe your outreach needs to be in that that language, or maybe you need to have community health workers who are also going out to help people maybe benefit from a policy. But when I really say policy making process, y'all are thinking this, or that school of rock, like, I'm a bill. So we have a bill is introduced, sometimes through advocacy. So maybe community members may actually be able to lobby their legislator and convince them to be the champion for a bill. After it is introduced, if you are lucky, it gets assigned to a committee, and then the committee can consider the bill. Maybe it needs to be reviewed by a different committee. And then if it gets to the floor, hopefully it passes, and then it might switch from the House, let's say, to the Senate. And then the Senate has to review, in committee, look over the bill. They may send it to the floor. They might tweak some things. So we see here, if the House and Senate bills, if they agree with whatever amendments, the bill is ratified, and then it could also be sent to like the president or the governor. So there are a lot of different steps. You may have worked on a bill that looked one way, and then when it is signed and becomes law, it looks totally different. And I will say the room where it happens gets smaller and smaller as the bill progresses. But I think there are opportunities in this, this twisted kind of path for all of us to have some impact on policy. So when we think about, who are key influencers in U.S. healthcare policy, I would say us. Probably all of us have been, our patients or have been consumers of healthcare at a point. So again, even if you just want to share your story, professionals, providers, you are a trusted voice that has the expertise, and you went to school for a gazillion years and then had residency and things like that. We can also think about our insurance companies. I know that sometimes insurers get labeled a certain way, but there are opportunities maybe for collaboration. Employers. So again, all of us probably have on some type of hat that allows us to be an advocate. And then I would say, if you have a passion project or a policy that you really want to work on, you kind of have to ask yourself, like, the question, like, what is the outcome you want? Do you want universal health care? Do you want to repeal something? Do you want to allow more types of providers to, work up to the top of their licensure? There could be a whole lot of things. So you got to think about that. A lot of times coalitions work. I know some of us don't like doing group projects and group work, but coalition building and working together and bringing together a lot of voices is powerful. And then kind of develop this shared vision. This image here is the theory of transformation. It's a little bit older, but sometimes I like to remind my students that we can't just all blow things up and disrupt everything, just like that. So I like this in that it says that sometimes we have to work within the current system while still trying to, be also have a bigger dream for something better. So kind of thinking about what are some small opportunities and wins that we can have. Not everything has to be the big P policy on the federal level, but what are some things that we can do here in North Carolina? What are some things that we can have here in Orange County? Because I will say state policy can inform federal policy. Before the ACA was Obamacare, it was Mitt Romney care. It was modeled after what was happening in Massachusetts. So, states can inform federal policy, and it kind of goes back and forth. So I think you can also start small. More thinking about, what are some of the strategies. This is, a behind the scenes of a press event at the North Carolina General Assembly. So you can see someone in a white coat in there, but, thinking about the tools that you have. What is your target audience? Is this an issue or a problem or a policy solution that not many people know about? Maybe you want to go to community meetings and, kind of build up folks who are in support. Or maybe you want to go directly to a legislator, because you know that they have a personal connection to this issue, or that they've tried to pass a similar bill in the past, and you're like, I think you'll have the backing. Also thinking about your timeline. Medicaid expansion took many, many years. States could have expanded Medicaid starting in 2014. North Carolina didn't do it till 2023. So sometimes it is a long, slow path. And then you need to check in a lot with your partners and think if language has changed. And then, we got to celebrate the short term things. It can be overwhelming at times, but even just playing defense and stopping a bad bill is something that's worth celebrating. And then we want to evaluate. So, are we collecting data to show that this policy is working? Here are some tools. So this is like when Governor Cooper signed the Medicaid expansion bill. We can see so many different people in the background, and just celebrating years and years of work. So some of our advocacy tools, I showed a picture of a press event. So kind of getting media attention is helpful. Community education in this room, in any other kind of group or social gathering that you have. Storytelling. I know being uninsured might have a stigma, or being underinsured might have a stigma, but stories really matter. We kind of need to humanize so that people can put a face with policies. Negotiation, a lot of times there's some give and take. Some organizations actually plan big advocacy days where they bus a ton of folks to the legislature. Your research, if you're a researcher, being willing to work with community groups and advocacy groups, signing petitions. Sometimes you might get that phone call or that email. And if it's just a click, why not add your name just to fill someone's inbox for the day? You can be a lobbyist yourself. Like, you can call up and do that, or you can attend events. I can talk about bird dogging later, but you can also join advisory councils and coalitions. So there's many ways to do things. So I'll just close it with, do you think it's important to get involved in the policy making process? Why or why not? And what roles have you had in, maybe in trying to influence policy? And for those of you who are still in training and learning, how do you see yourself? I welcome to hear from all of you, or if you want any tips and tricks in getting in the policy advocacy space, or just feeling more comfortable reading about policy. There are some podcasts and some websites that I also can recommend. With that, just want to thank you for having me. I know it's very different than talking about glaucoma and other topics, but appreciate your time. Questions, feedback? Bird dogging. So it used to work, I think, more in the past, but let's say someone running for office is kind of having a town hall. And you might so when we were doing Medicaid expansion, we would have people show up to sometimes these policy events and purposely ask a question. They might not want to talk about Medicaid expansion, but you're putting them on the spot. Nowadays, people kind of screen questions more, but there may be ways to put, a potential elected official on the spot and ask them about a topic, so that you can have them on public record saying, I'm going to support this bill. And then if they don't do it, you call them out and hold them accountable. Sorry, the question for those on Zoom was like, what is bird dogging, which was on, I think, the second or third to last slide. Yes.
Thank you so much.
Thanks. Get us ready for the fight, right? Yeah, so the question was, is there anything good in HR 1? For some folks, they think that rural health transformation program is helpful. In a state like North Carolina, I forget where we rank for rurality, but we're high up there, like behind Texas for like the most rural areas. But then when you, like, I did put in that little twist, like, but rural areas are going to lose Medicaid dollars. But I think lifting up the rural experience might seem as one thing. I think it also probably depends on your political views. For some folks, this is a great bill, and maybe curb some healthcare spending. That has been a concern for many years. But from other provisions, I haven't really seen too much great stuff. Yes. Medication. So the question was, does HR 1 have anything about medication affordability? I am still getting well versed on that, but what I would say is that from the Biden administration with the Inflation Reduction Act and thinking there was the negotiating of drug prices. So there were like the first 10 group or the first 10 drugs in which the federal government negotiated with pharmaceutical companies to try to control the cost, and also holding pharmaceutical companies accountable for how much they could increase the cost of drugs. So I think that is continuing, but maybe not in HR 1. Anyone else? All right.